The spine, once thought to be a purely mechanical structure whose degeneration was largely irreversible, is now at the forefront of regenerative medicine. At the core of this transformation is a deeper understanding of how cellular senescence contributes to intervertebral disc degeneration, a key driver of chronic back pain, spinal stiffness, and impaired mobility. Rather than simply removing or replacing damaged discs through surgery, scientists are increasingly focused on biologically restoring disc function by targeting the root causes of degeneration. This shift, from replacement to regeneration, has given rise to a new class of therapeutic strategies centered around senolytics, stem cell therapy, and gene editing. Senescent cells, those that have stopped dividing and entered a dysfunctional, pro-inflammatory state, accumulate in spinal discs as we age. These cells secrete a toxic mix of cytokines, proteases, and oxidative compounds collectively known as the senescence-associated secretory phenotype, SASP. The result is a localized storm of inflammation and tissue breakdown that weakens disc structure, reduces hydration, and makes the surrounding environment hostile to regeneration. Crucially, these zombie cells not only fail to repair tissue, they actively block healthy cells from doing so and can even sensitize nearby nerves to pain. Senolytic drugs, which are designed to selectively eliminate these senescent cells, have shown promise in reversing some of these pathological changes. In animal studies, the removal of senescent disc cells using senolytics like ovanillin or the dasatinib, quercetin combination has reduced inflammation, preserved disc structure, and improved spinal mobility. These findings suggest that by clearing the biological clutter caused by senescence, we may be able to reset the local environment, making it more conducive to healing and less prone to chronic pain. But clearing the dysfunctional cells is only the first step. To truly regenerate the disc, we must also restore or replace the cells that maintain its structural integrity, primarily the chondrocyte-like cells of the nucleus pulposus. This is where stem cell therapies come into play. Injecting mesenchymal stem cells, MSCs, which can differentiate into cartilage-producing cells, has already been tested in early clinical trials with encouraging results. These cells can help rebuild damaged matrix proteins, stimulate endogenous repair mechanisms, and even modulate inflammation through the release of beneficial signaling molecules. When combined with senolytics, stem cells may have a clearer, more receptive environment in which to engraft and function, increasing their therapeutic success. Gene editing, though still largely in the preclinical stage, offers an even more targeted approach to spinal regeneration. Using tools like CRISPR-Cas9, researchers can potentially correct the genetic or epigenetic drivers of premature cellular aging in disc cells. For instance, they could silence genes that promote senescence or enhance expression of genes involved in matrix synthesis, antioxidant defense, or anti-inflammatory pathways. Gene therapy could also be used to engineer stem cells with enhanced resilience to the harsh, low-oxygen conditions inside the disc, giving them a better chance of survival and long-term functionality once implanted. Together, these strategies represent a powerful multi-pronged approach. First, eliminate the senescent cells that are poisoning the tissue. Second, replenish the disc with healthy, functional cells via stem therapy. And third, reprogram the local environment with gene editing to sustain regeneration over time. This holistic model stands in sharp contrast to current surgical approaches, which often involve removing degenerated discs and fusing adjacent vertebrae. While effective at reducing pain in some cases, spinal fusion does not restore natural biomechanics and can even accelerate degeneration in neighboring discs due to altered load distribution. The regenerative route not only holds the promise of better long-term outcomes, but may also delay or prevent the need for surgery altogether. Patients could receive a combination of senolytics and biological therapies early in the disease process, before structural collapse or nerve compression becomes severe, offering a way to preserve native tissue rather than replace it. Such an approach could dramatically shift how spinal disorders are managed, especially in aging populations where the burden of back pain is both enormous and growing. Of course, significant challenges remain. Delivering therapies into the disc, which is avascular and poorly accessible, is technically complex. Ensuring that senolytics don't harm healthy tissue or that stem cells don't differentiate into the wrong cell types requires ongoing safety refinement. And gene editing, while powerful, raises questions about long-term stability, off-target effects, and ethical considerations. But the rapid pace of innovation in these fields is encouraging, and early clinical trials are already paving the way for broader adoption. In conclusion, targeting senescence in the spine is not just a novel idea, it is a paradigm shift. By focusing on the cellular roots of disc degeneration, we move beyond symptom management and toward true biological repair. With senolytics to clear the path, stem cells to rebuild the structure, and gene editing to guide the process, spinal regeneration may soon become a practical reality. This integrated, minimally invasive strategy could redefine spine care, offering not just pain relief, but restored function, improved quality of life, and a new standard for treating age-related disc disease.